So, what's in it? And I use on my talk, I use a lot of information from the North Carolina Institute of Medicine, from Kaiser Family Foundation, from a lot of other research places. So I'm stealing, and I will give full faith and credit to all those folks from whom I'm stealing. That a lot of this National Institute of, or National Association of Free Clinics and things like that. But to start, what was the premise? Why did they do this? Why did they do this massive change? The idea was three different things. They wanted to address cost. Healthcare costs are skyrocketing. They wanted to address access. We've got 50 million uninsured people in this country, and they wanted to address that. And also quality, that we're paying outrageous amounts as a country, and our health outcomes are lower than all of our industrialized partners in the world. So these were the premises behind this act. And how well they did, we get to judge over the next couple of years, but this was what was going into it. It is over 1,000 pieces of legislation, 2 different acts signed into law in March of 2010. And what its premise is, what it's supposed to do, and stay with me because there is some details in this. So if I get too much in the weeds, ask me a question, do interrupt, feel comfortable doing that. But on a state-by-state basis, folks will be, low-income people will be eligible for expanded Medicaid. We know the Supreme Court changed that a little bit. It was good, in the bill, it was supposed to go to everybody. The Supreme Court said states got to choose. Most individuals have to purchase insurance if they don't have public coverage or employer coverage. There's that individual mandate we hear about. And folks who are less than 400% of the poverty level, do y'all understand federal poverty level? Most of us? Okay, yeah. They're eligible for some subsidies to help purchase the cost, offset the cost of insurance, of purchasing. Businesses are, yes ma'am?
What is the dollar amount on the federal poverty level?
It changes annually. In February, the feds put out what it is. Right now, for 2013, it's $11,490 is 100%. So 400% then becomes, for a single person, $45,960 pre-tax. So anybody who's making $45,960 pre-tax is eligible for some level of subsidy.
Thank you.
The only way to get the subsidy is through the exchanges, through this online system that's, we know has worked so well so far. But anyway, the subsidies are on a slide. So if you're at the highest end of the poverty level, if you're at 400 or 399% or whatever, then insurance becomes not more than 9.5% of your AGI. So it's a slide. If you're at the bottom, if you're at 100%, then the cost of purchasing that insurance is not supposed to be more than 2%. So the subsidies are on a calculated slide based upon your income. It's not that everybody's going to get the same subsidy or the same amount. It's based really on your income. And there's supposed to be a maximum for out-of-pocket costs, but that's been deferred for year 1. And I'll talk about that in a minute. Large employers, those of over 50 full-time employees, over 50 people working 30 hours or more a week, have to provide insurance or face penalties. Small employers, under 50, don't have that mandate to offer insurance. But really small employers, and this is where my company fits in, and a lot of smaller nonprofits, if you're under 25 employees, you get an incentive to offer insurance. It's not huge. The clinics has received between $750 and $1,000 for the past 3 years because we offer insurance to our employees. And it's, again, a very complex calculation that our auditor does because we couldn't do it, but based on salaries and percentages and coupon. So there's an employer dimension, but it really factors into the larger employees. The smaller ones don't have the mandate. The goal of insurance reform, the goal of this, was to cover more people, to eliminate pre-existing conditions, that huge thing that kept people out, to eliminate lifetime maximums. All the stories we hear about the people who were the good, solid, middle-class family that had some horrific health thing and ended up being homeless and everything because they maximized maximize their coverage and had to sell everything they owned. To provide good insurance. I can't tell you the number of stories of folks who walk into our doors. We're the free clinics. We do safety net services in Henderson and Polk counties. And the number of people who walk in our doors who have really awful insurance. I use one example of a person who worked at a fast food. They took $20 a week mandated out of her check for coverage. No, excuse me, $20 a month mandated out of her check, covered for coverage. Okay, so $2,400 a year they were taking away from her for coverage that was a maximum annual of $2,500. Yeah, so she got a $100 benefit out of this, and her drug coverage was $1,000, and she came to us through annual. She came to us through our mental health program, needing help with some medications because she'd used up her maximum in 1 month.
Wow.
But because she was insured, bad insurance, but insured, none of the drug companies would allow her to get free medications through the drug companies. She couldn't use our pharmacy and some of the benefits that come. She wasn't qualified for hospital-based charity care programs or anything like that. She was insured, but it was really bad insurance. So the idea is that those kind of insurance plans are supposed to go away. This is what the premise of the bill is. Do y'all understand Medicaid, what it covers and what it doesn't? Because a lot of people don't. Medicaid does not cover all poor people. Doesn't. The old idea of expanded Medicaid wasn't to make it more poor people covered under Medicaid. It was to even out access. Because right now, the only people who can have Medicaid are children. If you are determined disabled, you've been designated disabled by some other institution, federal institution, or you're a low-income senior, and you have the Care-Cade companion. Otherwise, and some really, really low-income parent of a child, but that's it. If you're a single person with no income, there is no and you're not disabled, there is no Medicaid. Just isn't. There's some emergency Medicaid that will cover a life-threatening illness, but that is for that illness, and once it's done, it's done. So the idea behind expanded Medicaid, what the controversial thing that went to the Supreme Court, is it was just to even it out. Everybody under 138% of poverty level could have access to Medicaid, could have access to an insurance. That was all it was. And the Supreme Court made it a state-by-state determination, and we're about 50-50 right now on the states that have accepted the expansion and not accepted the expansion. North Carolina has not. One of the pieces that was in that, one of the unintended consequences of the Supreme Court ruling, the subsidy scale, and somewhere in my paperwork I have a picture of the subsidy scale. The subsidy scale starts at 100%. If you're less than 100% of poverty, there is no subsidy. Nothing. Nothing. There is no benefit to being for the ACA for people who are under 100% of poverty. And as an example, in Henderson County, I know my statistics better than some others. Excuse me if you're elsewhere. There are 7,707 people who are under 100% of poverty who will have no benefit from this whole big mess of the Affordable Care Act. None. They're uninsured by the State Institute of Medicine's determinations. Here it is. They're uninsured and they will have no access to benefits. So you can see it starts at 100%. If you're under 100%, there's no benefit. No subsidies, no slide, no nothing. So that's one of the dimensions with Medicaid in those states that didn't do it. And if you roll that out.
Is it different with the states that did accept it?
Yes, sir. In the states that did accept it, the way the act was written is that the bottom tier economically would have expanded Medicaid. And then the subsidies would help the lower income working class kind of folks. And then ideally above the subsidies you could afford to purchase, and it would be better insurance, and it wouldn't have the lifetime maximums and the pre-existing condition caveats.
So what is the way you would explain the reason the state of North Carolina did not accept this?
He's taking right into the
You and
political
I.
waters, don't you? The answer coming out of Raleigh is that they feel like Medicaid has some challenges, it's had overruns, it's broken, is the language that's coming out, and that they want to fix the system and have it work well before they take on all of these additional pieces. Yes, ma'am.
So Judy, to go back to your 7,707 people, for example, so they are uninsured, they're not getting Medicaid, they're living at roughly $12,000 a year, something like
11,500.
11,500. And so they are now sick. So they're gonna go to the hospital, right, for the hospital to pay for their care, hopefully. That's the system that we have right now.
Well, actually in Henderson County, we've got a really dynamic, and in a lot of the western counties, we've got a really dynamic safety net system. So it's, and I'll talk about the safety net system. Blue Ridge is a key dimension of the safety net system. All of our federally qualified health centers, hospital charity care, free clinic systems, there are rural health centers and things like that in other parts of our community. So there is a safety net that exists to help support those folks. And and North Carolina is looked to as a leader in our safety net in the nation. And Henderson County, just as the personal, is looked to as a leader in North Carolina as far as how our safety net functions and how well we work together and how collaborative there is so that we try and make it seamless for patients. The challenge with the way the Affordable Care Act is rolling out in states like ours is there's a public perception that it's all fixed. Right? There's a public perception that the act was intended to help poor people, so poor people are going to be helped, so we don't have the same need for the safety net. And that's where one of the challenges is coming in, is how do we make sure that we can keep the strength of our safety net when there's this public perception. The other dimension of the act is payment. There are, and you can read here in Buncombe, Ron Paulus has been in the papers about what the impact of all of this is going to be on missions, bottom line. In Henderson County, Jay Kirby's been in the media about the impact on Pardee's bottom line. There is an impact on hospitals. There is an impact on our federally qualified health centers in that they get a grant to help support their uninsured folk. And written into the bill is those grants go away over a period of years. But without increased Medicaid, there's a big gap. There's a gap for hospitals, there's a gap for the FQHCs, there's a gap for a lot of folks with the payment structure that was written into the plan. So when they took away the expanded when states chose not to do expanded Medicaid, it leaves still that pocket of people without access to care, but ultimately no payment source coming in for them. Because the grants go away and there's no Medicaid. And that's this huge impact on the safety net that is gonna impact and roll out and ripple out to all of the work that we do. And that's, I think, part of the fear factor that Annie's feeling, that I'm feeling, that I'm trying to talk about, that I'm sure that Milton would probably echo. There is this piece, and I keep pointing to him, he's my partner at the Federally Qualified Health Center in Henderson County. If y'all don't know Milton Butterworth, I'll be introducing him to talk a little bit in a few minutes about what they're doing.
But what it means is then that the hospitals are going to be out doing more and more and more fundraising.
Yes,
because
ma'am.
they're going to have to pay for that, which means that the rest of us are going to be in worse competition with one another.
Exactly.
Well,
All the safety
plus
nets.
shift, try to shift services to outpatient.
Right.
And then it gets to outpatient as possible instead of inpatient.
And all of the safety nets are going to be out doing that. So in Buncombe County, you'll have ABCCM, you'll have the Western North Carolina, the Western Health Community that runs Project Access. You'll have all of those safety net providers out being more aggressive about their messaging, because they have to be. Because the only way they can sustain services for folks, and there's no change in need, but the only way they can sustain services is to be more aggressive about their messaging. And I will say, in my community, I've been louder and more vocal than I've been in years in the public forum for that reason, to try and get that message out and to engage folks in more fundraising, more donations. Not to take away, because there's public perception that it's all fixed, but to actually increase.
If the state had said yes, would that put the safety net structure in jeopardy?
It would change the dynamic with the safety net structure. would stabilize some of the safety nets that have that utilize payer sources. The FQA, the federally qualified health centers, the hospitals, those that take third-party payment sources that are major players in the safety net would not have the challenges to a loss of funding. Some of us, like ABCCM here, Asheville Welcome Christian Community, and their medical ministry, like Project Access, some of us who don't do third-party payment sources, it would change the dynamic a little bit, but it wouldn't be quite as fragile.
Would it be fair to say that most of the people in the safety net structure would be for the state of North Carolina to actually approve this?
The Hospital Association is very much vocal that North Carolina should have taken it and is lobbying very actively to that regard. And they're a significantly, probably the largest player in any of the safety net messaging or any of the safety net services are the hospitals. Whether it's the mission hospitals or the smaller Transylvania and St. Luke's, the smaller hospitals that are in smaller communities, they're the ones who are taking probably the biggest hit. And the Hospital Association has been very aggressively saying this needed to happen, and we still can go back and fix it. Any of the states can at any time go back and change their mind, except that the only caveat to that is there's the federal investment in the new Medicaids, it's the newly eligibles. It's got a timeline on it. We're going to do this feds will do 100% for a period of time and then taper it down to 90%. By 2016, it goes down to 90%. So if you opt in late, it's not like the clock starts then. Whenever you opt in, it's where the payment mix is. That right now, if North Carolina, if the other states, and it's the South is really kind of solidly. Actually, if you Google it, there's a map on who took, and whoever designed the map was not very creative in their color coding, so it's red and blue, and pinks and light blues, and purples for those who are doing this kind of weird system. And if you imagine our electorate map in your head, you kind of can match up the reds and blues. I wish they'd chosen like purple and green or something, so it wouldn't be quite so obviously political, but I didn't do it. I was answering your question, Alex. I'm sorry about that.
No, you've done a great job. Thank you.
For Medicare, there's not a whole lot of change for the individuals. There's some talk right now about Medicare Advantage and how that might be affected. But if you have Medicare, as the individual, you're not going to experience many changes in your life, except more of your preventative care is covered with no copays. But what is going to happen with the Medicare side is reimbursements go down. So the physicians, the providers, the hospitals are seeing less payment source for Medicare because some of that was supposed to be helping to subsidize the Medicaid and some of the other subsidies and things like that. Every insurance is supposed to have an essential benefit package. And this is a big thing in the press too. But it must cover hospitalizations, professional services, doctors, things like that, prescription drugs, rehabilitation and habilitation services, mental health and substance abuse at parity, which means the exact same kind of coverage you get for medical, you get for mental health, preventative services and vaccines, maternity care, well baby, well child. It's all covered in there. And there's a lot of stuff right now in the press about, well, the 60-year-old woman doesn't need baby coverage, or the 60-year-old man doesn't need well child coverage, or something like that. What you need, and that's a political statement, it really is, and this is where I'm going to kind of get into the weeds a little bit. The insurance actuary people who set the rates, and the rates are still age banded. There's a limitation on age banding, and it only can be 3 to 1, but there's still an age banding. And those people factor in, okay, this 60-year-old man or the 60-year-old woman, the likelihood that she's going to get pregnant is like this, so the amount added to the premium is very minimal for that age banding. There's a lot of talk about, oh, they don't need it, and so that's what's jacking up prices. That's really not, because you have the same kind of insurance commissions and actuaries looking at pricing for the appropriate age banding. That was my side note. Preventative services are supposed to be covered with no co-pays, no co-insurance. 10 minutes? All right. So that's why you get your colonoscopy covered, or your mammogram covered, or whatever. No limits for pre-existing conditions, no lifetime annuals, mental health parity. There's 4 levels of coverage. Bronze covers the 60%. So the insurance pays 60%, you pay 40%. Silver is 70-30, gold is 80-20, platinum is 90-10. The subsidized coverage that you can go onto the exchange for low-income people buys the second tier silver coverage, which means it's going to help subsidize a 70-30 split. And this is something that clients don't always, especially low-income clients who haven't had insurance, don't necessarily understand. They go on, hey, I can buy insurance, $12 a month, I get insurance. But that's a 70-30 split. And if you're a chronically ill person with lots of provider relations and lots of medications, you're paying 30% of every drug cost, 30% of every doctor visit, 30% of every hospitalization if that's your need, at every time. And those add up significantly. I mean, we have patients whose drug cost would be about $2,000 a month if they were out of pocket. So 30% of $2,000 is a significant monthly payment. And that's something that I don't think a lot of our lower income folks understand who haven't had insurance in the past.
What about the deductibles for those levels?
What do you mean? 70.
The limitations.
Yeah, when we're, how much out of pocket?
There is supposed to be a maximum out of pocket. And it's supposed to be it's something equivalent to what the HSA annual contribution would be a year. There's a calculation based on that factor. However, because they can't figure out how to make it work, they deferred that for year 1. So there is no max out of pocket.
Whoa.
What you need to understand is that there's 1,000 pages of text of this law, and then for every dimension of that, there are rules that have to be written. And there's a whole other set of branch of the government that just writes the rules. 6 months ago, there were still 4,000 rules yet to be written.
We gotta pass it first.
Right. 4,000 rules yet to be written to make this effective. So you'll hear about they're deferring this or they're deferring that for year. They've deferred the employer mandate for year 1. They've deferred the max out of pocket for year 1. They've deferred. It's because they haven't written the rules. And sometimes because they can't figure out how to write the rules. Because how do you figure out how to do the max out of pocket? And you go to that doctor, they're going to send you a bill. Or you go to the pharmacy and they want their payment for the drugs. How do they get the max to make sure that that drug gets paid for after you've maximized your out of pocket? And they haven't figured out how to make that work. So they just deferred it for a year. We've told about the marketplace. It's supposed to be easy. We know it's not so easy. We know it's not working so well. One of my favorite graphs about why it's not working so well, and then I'll skip ahead to what the impact is. Okay. This is you sitting home on your laptop in your pajamas at night trying to figure it onto the marketplace, right?
Mm-hmm.
If you have that laptop and you have that sophistication. It doesn't just, you go plug in your information and it's supposed to be easy. It's going to go check with Social Security Administration and verify that you're really a citizen. It's going to go check with ICE or Department of Homeland Security and make sure that you're not a person of interest or something like that. It's going to go and check your immigration status. It's going to go to Employment Security Commission and verify your wages. It's going to go to IRS and verify your annual income. It's going to go to Department of Labor and verify that your company's not supposed to be providing insurance. Part of the reason why it's not so easy. And if you're not sophisticated or technically savvy, you have to rely on the navigators, which is where Blue Ridge comes in, or DSS, or something like that. Because the only place for low-income people to get the subsidy is through the marketplace. Okay. I'm going to skip ahead, because there's all this technical stuff, and y'all feel free to ask me any questions. But to the local impact, North Carolina, the estimates are 1.5 million uninsured, 19% of the non-elderly population in the state. And of course, we opted not to expand Medicaid. And I'm going to talk about Henderson, because that's what I know. So about 110,000 residents in Henderson County, 57% of whom are in that 18 to 64 range, which is what we're talking about. Because kids can have Medicaid, seniors have Medicare. Right. 30% of Henderson County residents are below 200% of the poverty level, and 13% are below 100% of the poverty level. So 13% don't qualify for anything. 22% are uninsured. That's from the North Carolina Institute of Medicine. So one in 8 of our neighbors in our community has no benefit from all of this mess. 1 in 8. And for the patients that Free Clinic serves, we work at 200%, it's 1 in 5 are eligible. And if you're at that bottom percent of poverty, you're making that decision, is it worth enrolling and paying $127 maybe at the bottom for your insurance for the year with no out-of-pocket, no max out-of-pocket, or a $95 a person penalty? Because there are penalties that are going to factor in, but the penalties are relatively low compared to the prices or costs. The safety net in our community, and I refer to this, and I speak as the immediate past president of the Association of Free Clinics for North Carolina, and we are recognized nationally as the leading state for free clinic and safety net services. So I have a sense of what this rest of the state looks like and what the rest of the nation looks like for safety net services. Ours, and I say this with a bit of pride, is the strongest safety net in our state, in our community, which is then, roll it out, one of the strongest safety nets in the nation. We have in our community 100 healthcare partners who actively work to provide safety net services within our community. I already talked about the impact on hospital and federally qualified health center, and all of those doctors' offices who take care, who work with us, who are part of those partner networks, are looking at no reduced Medicare, no Medicaid. They're looking at their bottom line tightening as well. So our safety net, which has been incredibly strong, is now extremely fragile. And it's not just my work, it's the work of all of our safety net partners. And this is going to change healthcare in a way that nobody understands. We really don't know what healthcare is going to look like a year from now, and how the systems are going to work. And everybody right now is just trying to figure out how to keep going with less money, more patient, or no change in patient need, and to keep trying to work together and make sure that we have a way to take care of each other. This is going to impact all of our world. Excuse me, I have some of our nonprofit partners down in my community that are thinking about canceling insurance that they may have provided and incentivizing their employees to go to the exchange, because they know that they can get better rates through the exchange than they can paying for insurance directly as the company. The small business part of the marketplace has again been deferred because they can't figure out how to make that work. So there's supposed to be an opportunity for small businesses to be able to enroll and get better pricing, but that's been deferred as well. So it's a really hard place we are right now. Blue Ridge, our local partner, is doing enrollment. They're a certified enrollment office. What's it called?
Certified Application Counselor Organization.
Aha. I know they have certified enrollment specialists. That's
Yes.
really cool.
Yes.
Plus Pisgah.
And Pisgah has some up here that are working.
Well, they have some, they'll have some, they have some down there.
And there's enrollment specialists and there's also navigators. So there's 2 different roles that are working to help try and enroll people. And those who qualify for the subsidies and can get some benefit tend to be the higher percentage of poverty. Kaiser Family Foundation has a really interesting graph where what the Affordable Care Act is doing to the lower income versus the higher income. It actually is a benefit for middle income, upper income folks, because you get better insurance. Your prices may adjust, because they are adjusting, but there's better insurance, no out-of-pocket for all the preventative services, things like that. But for the lower income people, which is what the bill was trying to talk about, is all those uninsured folks who couldn't afford, it's not doing well.
Let me just say, our chapter has a commitment to your time, and we always say that we will end at 1:30. I know if you are willing to stay and interested in staying, that Judy will continue to speak, and I know Melton would be glad to have a few remarks. So if you would like to leave, we understand that. Please feel free to, but maybe do so quietly, and we can continue the conversation for those. Is that all right? You okay? Okay, good, great, thanks. So how about 5 more minutes, you guys?
We'll let people move out as they need. need to, and then, I'll answer any questions. If Milton wants to join me and, say a few words and answer any questions, but please don't.
We all
have
thank
them.
you, Judy. That Questions?
Sure, I think, yeah, I think the, just to kind of let you guys know where we are on this, as Judy said, there's no question, we're looking closely at how the Affordable Care Act wrote in the way funding would change for community health centers over time, over the next few years. And as Judy said, with Medicaid expansion, that was supposed to offset the need for our base federal grants. We're watching that closely. The federal government has invested an enormous amount of money over the years in the community health center system. There are over 1,500 locations across the country, over 1,500 grantees across the country with more than 8,000 locations. So we're pretty optimistic that the federal government will come up with a fix for that cliff. The problem, I think, that we want to all be careful of is, and keep it in front of our elected officials, is oftentimes the federal government will start to deal with the problem as the problem is actually happening. So if the federal government waits until 2016 to address the problem that is going to happen in 2016, we can see a period of time of, say, 6 months, 8 months, where community health centers that are in states that have not expanded Medicaid don't get those additional reimbursements while the federal grant drops. So we want to keep a close eye on that. Whether North Carolina and other states expand Medicaid or not, it's likely that the federal government will create some type of a fix. I think the federal government and many of us are hopeful that North Carolina and other states will yet expand Medicaid. And I think we can still be hopeful about that. We can still communicate that to our state elected officials, that we think that that's the best thing for the hundreds of thousands of North Carolinians who are currently left out of the process, really because Medicaid was not expanded in North Carolina. There's no question the Affordable Care Act is for the most underserved in this country, the folks who have not had access to insurance. And it's creating lots of complicating situations for folks like most of us who probably have insurance or had insurance before, my family included. One thing I would say in the area of optimism is we have received federal funding to not only educate the community and the public about this opportunity and how to access it, but as Judy said, we employ certified staff who are certified to hold your hand all the way up until pressing the button to choose insurance through the marketplace. There's no question the first 6 weeks of the rollout were a disaster. I think we enrolled one person in the first 6 weeks. California, with their state-run exchange, enrolled 30,000 in 5 days. So there was a massive problem where the government did not consider that this many states would not expand Medicaid. Remember, that was a Supreme Court decision that happened after the fact. And so with 36 states on the federal exchange sharing that bandwidth, it was a disaster waiting to happen. And you saw the graphic that Judy pointed out about how that website's, all the work it's supposed to do. The good news is, in the last 3 weeks, essentially since Thanksgiving, it has picked up enormously. And to their credit, they have fixed it now and launched the Spanish-speaking site. So that's really good news. On the English side, though, there remain bugs and glitches. Still, we have now completed applications for 300 people. That means that they've gotten all the way to the point of selecting some type of insurance. Part of the answer to the question around deductibles is in the choices that the health insurance marketplace is supposed to present you. So you input a bunch of information, and it's hard to answer questions about different situations without considering each and every one of our individual situations. So I would encourage you, if you haven't tried healthcare.gov, to test it out. Just get a feel for what some of your clients, some of your partners' clients are dealing with. It's really interesting. It's supposed to work kind of like Orbitz or Priceline.com. You're supposed to be able to put in the information about where you want to fly, and out spits a bunch of different choices. More direct routes, higher costs, maybe a stopover in a certain place. That's a very general, overgeneralization of the situation, but that's what it was intended to do. And we are seeing signs that that's improving, thankfully. Because as Judy pointed out, there are thousands of people in Western North Carolina that need access to health insurance coverage and are not able to effectively manage their health care without some type of coverage. Let me just cut to what exactly we're doing and how that might impact your clients and potentially your employees. I've got flyers that we distribute in the community that advertise. We maintain regular hours at a number of different locations, including Party Hospital. And the whole point there is, if you have questions about your own personal situation, then you really ought to talk to someone who's been trained and certified to answer your question. It's really hard, no matter how much Judy and I learn about it, to be able to answer questions about Karen's particular situation and how that deductible choice might factor in, or I'm getting divorced this year, how does that? Let somebody assist you. We're being funded to do that. And that funding got rolled into our base. So we're looking at this from the long term. We're in it for the long haul. And we are trying to remain as optimistic as possible that this is going to be an enormous benefit to many of the people that we're ultimately trying to serve in this region. So happy to be a resource. And as I said, we've got some flyers to sort of illustrate. You can call us, you can stop by almost any time. And then we're in a couple of different locations in the community. We are in Asheville. We will take folks from anywhere in Western North Carolina. So if it sounds like a good thing for you to do, depending on your client or your situation, come see us. There are a number of other Navigator organizations that are operating in Western North Carolina, most notably here in Buncombe County. Western North Carolina Community Health Services is an FQHC up here that is also focusing not on outreach at this stage, but on in-reach. So they're working specifically with their patients, and I'm sure be happy to answer questions. Another really big player, two other really big players in the community are the Council on Aging of Buncombe County, interestingly enough, who got a grant to serve like 17 different counties, bless their hearts. And their model is really based on the SHIP model, and so it's really volunteer driven. So look for opportunities if you're interested in this type of thing to become a volunteer or learn how you can help support the effort to get the word out. And then, of course, Physical Legal Services is also operating in Buncombe County. We're all trying to coordinate our efforts, try not to duplicate those services. But again, I'm going to leave some flyers that are specific to, we're working in Henderson, Transylvania, and Polk counties right now. And I think the big message would be, if you have clients or know individuals that need some specific help, that's what we're here to do.
Okay, thanks again for your talk, and we'll see you all again next month.